Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. Our topic is radiology regulatory changes for 2026. And our guest is Sandy Coffta, Vice President of Client Services at Healthcare Administrative Partners. Sandy, thanks for being with us again today.
Great to be with you, Brian.
So we have you on every few months, and we talk about the different regulatory changes going on, Medicare and things like that. And it seems like the big news right now is that CMS last month announced its proposed Medicare physician fee schedule for 2026, and this is the document that kind of guides what Medicare is going to be paying doctors for medical services next year. So it's pretty closely watched, and whatever they do has a big impact on doctors and kind of U.S. healthcare in general. What were some of the major points that we saw in the proposed 2026 MPFS?
So, as usual, we did see the change to the Medicare conversion factor, which was a positive change, increase of about 3%, and the first one since 2020. We saw an extension of the virtual supervision policy, also a good thing. In terms of surprises, there were some broader RVU adjustments that we have not typically seen as part of the proposed rule. Most concerning is a 2.5% work RVU efficiency adjustment, which CMS is applying to all non-time-based codes, on the principle that medicine has gotten more efficient over the past decades, and there hasn't been a large-scale RVU reduction, and they're kind of bypassing the RUC and the relative value process there a little bit. So we've got a case of the government gives and the government takes away. We have a win on conversion factor and a loss on RVUs.
Yeah, I was a little confused by it when they announced it, because they said, hey, you're getting this 2.5% increase in the conversion factor, but then when all was said and done, the payments are going to be down to radiology, to diagnostic radiology, by 2%. Nuclear medicine is going to be down 1%. And so how is that from this efficiency factor thing, and how is that going to be applied?
So as most people may not be aware, there are two major components to calculating Medicare fees. There is, you multiply your RVUs by your conversion factor to get the base national rate. So while we raise the conversion factor, which is typically the only change we see in the proposed and final rule, this year we cut RVUs. So the two kind of balance out. The only area where we are seeing a significant potential increase in reimbursement is for interventional radiology in the imaging center or office-based lab scenario.
Now, they also announced two separate fee schedules. Can you talk about what that means and how that's going to be applied?
Sure. This dates back to MACRA, the law that gave us MIPS and the Quality Payment Program in 2015. That said in 2026, there would be two separate fee schedules. There would be a 0.75 increase in the fee schedule for practices and doctors participating in what they call alternative payment models. And traditional Medicare participants would get a 0.25% annual update. For the purposes of this interview, we're mostly going to talk about the non-APM schedule, since that's where most radiologists fall.
And how do you think that this is going to work out in practice?
I think it'll be pretty smooth. Medicare has a pretty good handle on who participates in alternative payment models and who doesn't. And if you participate in one, you are likely aware of that. And I don't anticipate that that's going to be a major struggle for anyone.
Okay. And so we're looking at, with all these things, in there, we're looking at diagnostic radiology down 2%, nuclear medicine down 1%. and interventional radiology actually ticking up a little bit. Do you think that was intentional on the part of CMS, or is that just kind of how everything's sorted out?
I think interventional has more time-based codes, which are not affected by the efficiency adjustment, your patient consults and things of that nature. And also, as I think we'll talk about in a minute, the site of service adjustment that will make it more advantageous to perform these procedures in an office-based or imaging center setting also benefits those
Hmm.
groups.
Let's dive into that a little bit more. So, as you mentioned, CMS is moving to shift reimbursement from hospital settings into the outpatient environments. Why are they doing that, and how are they doing that?
In general, and we've seen this from commercial payers over the past few years, most notably Cigna, looking to push radiology into the imaging center where there are lower costs overall. Hospitals have higher operating costs. Imaging centers operate with less staff. They don't have the certification requirements of a hospital. They're able to provide those services at a lower cost. And Medicare is looking now to kind of push things in that same direction. They're also saying that in this adjustment that doctors who work in hospitals have more support for their services. Therefore, they don't need to be allocated as many what they call practice expense RVUs. So they are looking to lower that hospital reimbursement and cut those costs by reducing the reimbursement in that setting.
And how much of an impact do you think this is going to have?
That is kind of a question mark at this point in time. The one thing that a number of experts who have reviewed the fee schedule, the proposed rule and the fee schedule provided, were that the text of the proposed rule and the RVU tables provided weren't entirely in agreement as to when the site of service adjustment applies. So there are a lot of inquiries into CMS for clarification, and we will keep you apprised as we know more.
Okay. So I guess there are some other things in this document besides just the payment rates. One of these is the supervision requirements. Can you talk a little bit about what that means and what their proposal will mean in 2026?
Um, from a CMS perspective, it's good news. A lot of practices did switch to virtual supervision since those efficiencies came into place during COVID. And a lot of physicians appreciate that flexibility.
And this is the
So
idea that certain procedures like contrast and stuff can be supervised by a physician virtually without actually having to have them in the room. So the technologist can be setting the contrast up and administering contrast, and as long as a physician is available by some sort of video link, correct?
it must be video. But the caveat here is that the ACR is kind of looking in a different direction and looking to push more back toward having a supervising professional on site. So if ACR changes their accreditation rules and requirements, that could negate this change from CMS effectively.
Hmm.
Um,
So
so keep an eye on that.
So right now, so the CMS during COVID said, "Hey, since we're doing the social distancing and all that stuff, it's okay for radiologists to supervise these things virtually," and they're proposing to make that change permanent. But we're kind of waiting to see where the ACR comes down on that.
Correct.
Okay. Anything new with the quality payment program?
Um, One fairly significant positive change is the addition of what they call MIPS value pathways for both interventional and diagnostic radiology. These are kind of packages of measures that you would complete, and it actually requires completing a lower number of measures than traditional MIPS, which may make it easier for some radiology practices to meet the MIPS threshold.
Hmm.
But overall, scoring and submission requirements remain unchanged from 2025 to 2026.
Okay. And is MIP something that's required of all practices, or is it mostly just an alternative for some?
At this point, not participating in MIPS can get you quite a penalty unless you are below certain thresholds unless you have very low Medicare volume. or you participate in an accountable care organization or some other alternative payment model that exempts you from MIPS participation.
Okay, gotcha. So, the package, there's a few good things in there. Oh, and you know what? What actually one thing that just came to mind is CT colonography. So earlier this year, CMS started paying for CT colonography, also known as virtual colonoscopy for colon cancer screening. And that's a test that's been around for a really long time, but it's never really caught on. How is that going? What are you hearing from your clients?
We're hearing a lot of, it's taken a lot of time for hospitals and places to ramp up their efforts to advertise and build a program, but we are seeing a small uptick in volume as far as CT colonography goes, and we're generally seeing increased revenue there as well. So I think over the next few years, we'll continue to see growth.
Okay, let's hope so, because it is it's a pretty valuable test. It can be a lot less onerous on patients than doing a full colonoscopy or something like that. So we kind of have a couple good things in the 2026 MPFS, but it sounds like it's just there's going to be continue to be pressure put on payments to radiology. How much, and this is kind of stacked on top of cuts that have been happening every year for as kind of as long as I can remember. How much pressure is this putting on imaging practices? What are you hearing from your clients?
There's a lot of uncertainty around this, particularly with the new variables of the efficiency and site-specific adjustment. And it's kind of compounded by the fact that we are hearing about cuts to Medicaid and to the ACA marketplace that will likely leave millions of patients without coverage over the next 5 to 10 years. So there's definitely concerns that the pressures keep building, and hospital-based groups who have gone to their facility, their healthcare centers for support. The hospitals are also looking at these cuts and kind of tightening their purse strings. So there's really a lot of uncertainty about how we're going to get through this year. This year looks relatively neutral between the RVUs and the conversion factor change, but that efficiency adjustment I mentioned renews every 3 years, which means in 2029, they'll cut another 2.5% if this process goes into place. So we're obviously, we're tentatively comfortable for now, but looking ahead over the next 3 to 5 years, there's definitely reasons for concern.
Mm. And well, we covered in the imaging where we covered a study a couple of weeks ago that talked about doctors actually leaving the Medicare system, and the numbers are pretty low. I think they were somewhere in the range
Yeah.
of 3%, but it has been growing. Is that something that you see physicians doing, is just kind of throwing their hands up and saying, like, I'm not going to take Medicare anymore?
At this point, no, principally because in radiology, the lion's share of imaging is in older patients. They also frequently have hospital requirements to participate with the same insurances that their hospitals accept. So we're not seeing anyone really stepping away at this point. It's more looking at how we can change the system or how we can diversify revenue uh, to augment what we're losing due to Medicare cuts.
Mm, gotcha. And so where we stand at this point is CMS will, I guess, take comments on the proposed MPFS, but my experience has been that they really don't change too much. And it takes a literal act of Congress, to get a
Uh,
change made. Is that kind of your perception as well?
well, Medicare is a budget neutral program. So if they were to, say, eliminate the efficiency adjustment, that cut has to be balanced with the cut somewhere else. So we could see the conversion factor reduced. I don't think we're going to see any major changes between the proposed and final rule. We may see methodology changes and shifts in how things are calculated, but by and large, Medicare has the money to spend that they have, uh, and it will literally take an act of Congress to add additional money to the pot.
So they're kind of their hands are tied in some respects.
Mhm.
All right. Well, Sandy Coffta of Healthcare Administrative Partners, thanks so much for being with us. Look forward to talking to you again.
Thanks, Brian. Great to be here.
Signing off for the Imaging Wire, my name is Brian Casey.